So, very good morning. Today, I'll be talking about chronic ulcers of oral cavity. So, what do you mean by an ulcer? So, ulcer is any break or breach in the continuity of the epithelium, right? So, we all know about abscess ulcers. Abscess ulcers are very common in the mouth. Okay. So, in this chapter, we are studying about chronic ulcers of the oral cavity. So in the condensed introduction, classification, then what are the chronic ulcers, tuberculous ulcers, syphilitic ulcer, pemphigus, erosive lichen planus, then malignant ulcers, necrotizing stylometaplasia, and conclusion and reference. So let's start. So as I said, an ulcer is any break or breach in the continuity of the epithelium, right? So it's very common in the oral region. As we can see on the skin, we can see so many characteristic lesions, bullae, vesicles, everything. But in the oral cavity, when we come to the oral cavity, we can see mostly the ulcers, because any lesion in the oral cavity, it can easily get traumatized with the tooth, with the food and all. And it easily becomes ulcer, and the oral cavity, the epithelium is very thin. So most of the lesions we can see in the oral cavity is ulcer. So that's what they are telling on the, according to dermatology, it is there is a characteristic appearance on the skin, but when coming to the oral cavity, it has a non-specific appearance, or most of the lesions have a non-specific appearance in the oral cavity. So when the patient comes to the clinic, mostly he complains of this redness or burning sensation or pain or something like that. Mostly he comes with a chief complaint of this redness, burning sensation or pain, right? So first of all, in any case, we have to take the detailed case history of the patient, detailed clinical history of the patient. Okay, so based on the duration, ulcers can be classified into acute and chronic. Acute ulcers means, what do you mean by acute ulcers? It is only for, it was in the oral cavity for around 2 or 3 weeks back or something like that. But when coming to the chronic ulcers, it may be for a period of 1 month or maybe many weeks. Okay. So that is the difference between acute and chronic ulcers. And you have to ask the patient whether this ulcer was to be of a long duration, or it was just 2-3 days back or 1 week back, like that. Okay. So that is the difference between acute and chronic ulcer. And you have to examine properly whether it is single or multiple. You have to think of what you have to examine all the areas of the oral cavity, not only the tongue. You have to check the buccal mucosa, palate, ventral surface of tongue, everything. Okay, so you should have a key observation of that. So whenever a patient comes to the clinic, you have to take the proper detailed history of the patient. History of present illness, what you are taking, it should be in detail. Okay, that's the main thing. And sometimes the lesions may be solitary. Okay, sometimes you can see multiple lesions. Okay, and also you have to ask for whether there is recurrence of these ulcers, whether you got these ulcers 1 year back or 6 months back or something like that. So recurrent ulcers, you have to take the history of the similar episodes. Okay, history of these similar episodes. Okay, so that is, you have to ask about whether it is acute or chronic, or whether it is a recurrent type of ulcer. All detailed history you have to take, and diagnosis may be challenging and it is important to consider. Then only you can reach the differential diagnosis. Okay, so history should include duration and also the associated symptoms, pattern of occurrence, and you have to ask about the associated systemic conditions. So when you examine an ulcer, you have to examine all the areas of the ulcer. That is, you have to check for the floor of the ulcer, edge of the ulcer, margin of the ulcer, And this edge of the ulcer, it's very important that we can see different types of edges for different cases. Okay, so usually in a healing ulcer, you can see the sloping edges. So it's going to heal sloping edges. But it is very specific, that is in tuberculosis, it's undermined edge. And in syphilis, it's punched out edge. And in case of carcinomas and all, you will get rolled out or everted edges. So you have to check for the edge. And also you have to check for the induration also. So what are the questions you have to ask when evaluating oral ulcers? Okay, so as I said, you have to ask about the duration of the ulcer, whether it is ulcer. So from that you can write whether it is acute or chronic, and you have to examine for single or multiple, and check for the location, then duration, associated pain, induration, and other mucosal lesions also you have to check. And most important, that is, you have to check for the cutaneous lesions also. Most of the dermatological diseases, they are all associated with oral lesions, and sometimes the oral lesions may be the first to appear in the oral cavity before the dermatologic lesions. So you have to check for the cutaneous lesions, and also some systemic diseases, and you have to ask for the medications, what all medications they are taking, whether they have some allergies for these medications. Okay. Then coming to the classification, so what I have discussed is what is an ulcer, and what are you going to ask the patient about the ulcer, what type of case history you have to take, what all things you have to ask in the case history of an ulcer. Okay, so coming to the classification of ulcers, you have acute ulcers, chronic ulcers, and recurrent ulcers. So acute ulcer means sometimes it may be single or sometimes it may be multiple. So single ulcer, it comes in the form of sometimes in case of bite injury, thermal damage, or chemical drugs, or mechanical irritation, or radiation therapy. You may see the single ulcer, single acute ulcer. Okay, but multiple ulcers you can see in case of herpes infection. So it is viral infection. In most of the viral infections, you can see this multiple ulcers. Okay, in herpetic gingival herpes zoster, herpangina, hand, foot, and mouth disease, infectious mononucleosis, diphtheria, candidiasis, erythema multiforme, Reiter's syndrome, and so on. Okay, and you have to just go through this classification. Okay, and chronic ulcer, when coming to single chronic ulcers, you can see some kind of traumatic ulcers. And also, most commonly, it is tuberculous ulcer or CMV associated, cytomegalovirus associated ulcer, syphilitic ulceration, necrotizing xylem metaplasia, and also in fungal ulcerations, you can see this chronic single ulcers. Okay, blastomycosis and mucormycosis, histoplasmosis, and sarcoidosis. Okay, and chronic multiple ulcers, you can see necrotizing ulcerative gingivitis, bullous pemphigoid, pemphigus vulgaris, lichen planus, linear IgA disease. Okay, and recurrent ulcers you can see mostly in recurrent herpetic stomatitis, pyoderma gangrenosum, Sjogren syndrome, and many deficiencies, and cyclic neutropenia. Okay, so this is the classification of ulcer. And when coming to the differential diagnosis of recurrent oral ulcers, so when you are asking for the episodes of this, whether there is the recurrence of this ulcers, you have to think of herpes simplex or benign actus ulcers or Stevens-Johnson syndrome or systemic lupus erythematosus, or they are using some dental processes. Okay, and some are allergic to some kind of oral hygiene products, and also medications such as methotrexate and pemphigoid, pemphigus vulgaris, lichen planus. So these all show some recurrence of this oral ulcers. Okay. So we have already discussed this. Yeah, coming to the chronic ulcers. First, so in this portion we are talking about chronic ulcers, right? So single chronic ulcers means what we can see mostly in tuberculosis. Okay, tuberculosis, syphilis, and all you can see single ulcers. And tuberculosis ulcer, everyone nodes, what we have already done with this bacterial infections of oral cavity, and in that we have studied tuberculosis and syphilis. So in that we can see single ulcers. Okay, so tuberculosis, it's a chronic granulomatous infection. Okay, and it is by Mycobacterium tuberculosis, and it is yeah. So you can see, mostly you can see what all features you can see in tuberculosis. Can you tell me what all features you can see in tuberculosis? So you will get primary tuberculosis and secondary tuberculosis, right? So mostly the symptoms are what you have to, when the patient comes to the clinic, you have to ask, you have to take the history, whether they have fever, malaise, anorexia, weight loss, cough, night sweats, and all, whether there is the history of weight loss, chest pain, and all. So you have to check it out, rule it out, and any symptoms in the childhood like this. Okay, whether you have taken medications for this, like that, you have to ask. And also while taking, and you have to check for the lymph nodes also, because in tuberculosis, one of the main symptom, it is the enlargement of the cervical lymph nodes. Okay, and the oral ulcerative lesions in tuberculosis, it is it's not so common, but when you see tuberculosis ulcer, the oral cavity, it's mostly on the tongue. Okay, and regional lymph nodes are enlarged, matted, and slightly tender. And tuberculous lymphadenitis, it may progress to, sometimes you can see this abscess, this tuberculous lymph nodes. It may cause, there's a further infection, and it may open out as abscess. Okay, in case of neck swelling present, which is tender, show inflammation of overlying skin, and abscess form perforate and discharge the pus. You can see in tubercular, in cervical lymph nodes, you can see this lymphadenitis and the abscess, this tuberculous lymphadenitis, and you can see the matting of the lymph nodes. And coming to the oral manifestation of tuberculosis, most common oral manifestation, as I said, it is ulcer. Tuberculous bacilli enter the oral mucosa through the mucosal surface, and this lesion may present as ulcer, fissure, tuberculoma, or generalized enlargement of the tongue. Okay, initially the lesion in the form of a nodule or a pallid vesicle, which progress to ulcer. And soft tissues are more frequently affected. Sites include mostly the tongue, and also the soft palate, hard palate, gingiva, lip, floor of the mouth, vestibular and retromolar region, and recent tooth extractions. Okay, but usually you can see on the tongue. And the ulcer is irregular with ragged, undermined edges, minimal induration, and yellowish granular base. You can see this yellowish granular base. And its induration is minimal. Undermined edges you can see. Okay, and sometimes the ulcer is surrounded by tubercle soils. Okay, and primary oral tuberculosis associated with cessation of regional draining group of lymph nodes, and usually painful, may be painless in some cases at an early stage. So you can see a solitary crateriform ulcer with slightly elevated and indurated borders on the lateral margin of the tongue. You can give a differential diagnosis of carcinoma also in this, right? So you can see that there is most of tuberculous ulcer, you can see this induration, you can feel this induration, and so, or you can give the differential diagnosis squamous cell carcinoma also. Okay, we have to rule it out. And when coming to the differential diagnosis, infected traumatic ulcer, major aphthous ulcer, syphilitic ulcer, sarcoidosis, histoplasmosis, and some kind of malignant ulcer. And pain associated with ulcer can be treated symptomatically. So one of the chronic ulcers now you have studied is tuberculous ulcer. So tuberculous ulcer, what this is one form of tuberculous ulcer. Mostly you can see on the tongue and also on soft palate, hard palate, gingiva, lip, floor of the mouth, everywhere. And soft tissues are most frequently involved. And you can see the regional lymphadenopathy, and you can see the ulcer with ragged undermined edges and minimal induration and yellowish granular basins. Okay, it's usually pink, and you have to write the differential diagnosis also. Then coming to the syphilitic ulcer, so I'm going a little fast because you have already studied about tuberculosis and syphilis. So syphilis, it's a sexually transmitted disease by Treponema pallidum. And what are the clinical features you know about? Primary syphilis, secondary syphilis, and tertiary syphilis, right? So in primary syphilis, what is the site? It is penicillin male and cervix in female, and extragenital also you can see. And intraoral site mostly it is tongue and palate. So tongue and palate, and chagrin, we have already studied about chagrin. As you can see, this chagrin is raised, ulcerated, non-tender. So here the chagrin is non-tender, but tuberculous ulcer is painful, non-tender, non-bleeding, firm, flat, round. Okay. So the base is also indurated, rolled out edges, and shape it is circular or semi-dunar. Okay. So this is the chagrin of tongue, lip, and hard palate. Okay, chagrin. This is about the primary syphilis. And you can see the regional lymph nodes, it's firm, enlarged, rubbery in consistency. So that's about the primary syphilis. And when coming to the secondary syphilis, it usually appears 4 to 10 weeks after primary lesion. Skin manifests as fine macular or papular rash accompanied by alopecia. Okay, and also you can see succinate lesions on face characteristic of secondary lesion, and generalized lymphadenopathy. You can see, and painless, discrete, and non-adherent to the surrounding tissue. And in secondary syphilis, you can see this mucus patches, small, smooth, erythematous area or superficial erosion found on mucous membrane of uvula, oral cavity, palate, and tonsil. Okay, like you have studied about that snail track ulcer, right? So split papule, double papule, at skin fold, and angle of mouth. I'll show you. So, right, split papule and the snail track ulcer, and condyloma latum. It's grayish, moist, flat top, extra large plaque. So it's a plaque form of lesion, okay, associated with this syphilis, that is condyloma latum. And loose maligna, it's a kind of necrotizing ulcer lesion, you can see. So this is some kind of papillary or plaque form of lesion associated with this syphilis, condyloma latum, and you can see this loose maligna. And when coming to the tertiary syphilis, the lesion is gamma and result of hypersensitivity reaction between, it is mainly because of the treponemal antigens. Okay. And chronic granulomatous and localized lesion, maybe nodular. You can see punched out ulcer with vertical mold and dull red granulomatous base. Right. All stages of acute syphilis can present as ulcers. Chagrin and mucus patch are self-limiting. So mainly in syphilis, you can see the oral manifestation as chagrin and also mucus patches. Okay. Okay, this is the snail track ulcer. Chagrin. So once more I'll tell. So chagrin, it is associated with primary syphilis. The main site is lip, tongue, tonsillar region, and palate. Okay. Initially, it may be like a papule, then it will turn to what ulcer. It's punched out, non-tender, indurated, and associated with yellowish discharge. That's the typical lesion. And you have that associated lymph nodes, it may be firm and non-tender or palpation. And it is self-limiting and lasts for 2 weeks, and it heals with minimum scar formation. And coming to mucus patches, it's generally associated with secondary syphilis or a lesion characterized by appearance of oval red macules, papules, and mucus patches. And oral commissure, it shows split papule, Mucus patches seen as raised erosive areas covered by grayish-white pseudomembrane and surrounded by pseudo-halo. So, in secondary syphilis, you can see this mucus patch. Okay, and also you have to write about the split vacuole. Okay. In snail tract ulcer, and in tertiary syphilis, you can see the gumma. That's highly destructive lesion, and it may sometimes occur 8 to 10 years after initial infection. And you can see the most common site is tongue, and the lesion appears firm nodular mass. Okay. They subsequently ulcerated, form deep painless ulcer. Gumma of hard palate result in perforation, produce oro-nasal communication. Okay. And we have the VDRL test and also we have in chronic ulcers, in single chronic ulcers, we have studied about tuberculosis and syphilis. So in tuberculosis, what are the sites of occurrence of this ulcer? And you have to type what type of ulcer you can see, and it is painful. And when coming to syphilis, what are the three types of what are the three stages: primary syphilis, secondary syphilis, and tertiary syphilis, and what all are the lesions associated with each, and how are they appearing? And it is painless. Most of the lesions are painless. Okay, and in both cases you can see the lymphadenema. And in tuberculosis, tuberculous lymphadenitis, you have to write. Okay. And in syphilis, you have to write about this Chagray, mucus patches, gumma, then views maligna, split vacuole, condyloma latum, then snail tract ulcer. Okay, those are the new terms we have studied. Okay, so let's stop here. Thank you.